Good morning. The Insurance Committee of the Tennessee House of Representatives of the 113th General Assembly is now in session. Today is February 13. The time is few minutes past 10:30. Madam Clerk, please call the roll.
Representatives Sapicki, Davis, Freeman, Helton Haynes, Hemmer, Hicks of Hawkins, Hill, Johnson of Montgomery, Johnson of Knox, Lafferty, Mitchell, Ritchie, Rudd, Rudder, Sparks, Terry, Thompson, Vice Chairman Martin of Carroll, Chairman Kumar.
Here.
Mr. Chair, you have a quorum.
Thank you. Members, this is the first session that we'll be taking on some bills, so I thought it was important to remind you that the rules of the Insurance Committee are the same as from last year. You have a copy, but we will send you a new copy. Kindly review them. And of course, we have always followed the rules. Do we have any personal orders? Vice Chair Martin.
Thank you, Chairman Kumar. I would like to recognize Chiropractic Day on the Hill today, and I've got a whole roll of my office as well as some constituents that are chiropractors and chiropractic staff from Lexington. So welcome you guys to the Day on the Hill. Thank you for coming.
Representative Hemmer, you're recognized.
I think my friend to the right of me was a little too humble, and he didn't recognize the First Lady of Carroll County, who is in the audience as well.
Welcome. Any other orders? Seeing none, we will move on to our agenda. We have 3 bills on the calendar. First of which is House Bill 1691, being presented by Chairman Crawford. Chairman Crawford, we have a motion and a second. You're recognized.
Thank you, Chairman Kumar. Thank you, committee. House Bill 1691 is a bill that will ensure TennCare's third-party liability statute aligns with the federal statutes and guidance, which were recently updated by Congress through the Consolidation Appropriation Act of 2022. Congress added these clarifying provisions to ensure Medicaid will be the payer of last resort. This will ensure other responsible insurance carriers can't deny a claim for certain technical reasons, such as a date on a claim or the format that the claim has been submitted by. This bill will allow TennCare's third-party liability program to ensure that responsible third parties who is legally liable to pay for medical services received by Medicare beneficiaries cannot deny the payment in certain circumstances, which is in line with the federal requirements. It's my understanding that this is the practice that is being done now, and so they are compliant with the federal guidelines, and so this has no fiscal impact on the state whatsoever. That is the bill.
Thank you, Chairman Crawford. Members, you've heard the explanation. Do you have any questions? I think you have explained it completely. Without objection, then we are voting on House Bill 1691. All those in favor, please say aye. Opposed? The bill goes on to calendar and rules. Thank you.
Chairman. Thank you, committee.
Next item number 2 is House Bill 2022. We have a motion. Do we have a second? We have a second. Chairman Reedy, you're recognized on House Bill 2022.
Thank you, Mr. Chairman. The ground ambulance assessment was created in 2018 to help fill the gap between the expenses incurred by ambulance services to perform a transport and what Medicaid reimbursement for this transport. Without using any state dollars, the ground ambulance services pays into the fund that's drawn down over $20 million in federal funds that is then paid back out to these services based on the Medicare transport. House Bill 222 will extend the ground ambulance assessment for another year. So annually, we just come back and extend it for another year.
Thank you. Members, you've heard the explanation. Do you have any questions? Seeing none, without objection, we are voting on House Bill 2022. All those in favor, please say aye. Opposed? The bill moves on to Finance, Ways and Means Committee. Thank you.
Committee.
The third item on our calendar is House Bill 0916. Chair Lady Rudder. We have a motion. Do we have a second? We have a second. You're recognized on House Bill 0916.
Thank you, Mr. Chairman and committee. This bill is traveling with an amendment.
Yes, do you have, I have 12739.
Yes, that's correct.
Okay,
And it rewrites the bill.
all right. So members, we have a motion and a second on attaching the amendment, and then the bill can be explained. All those in favor of adding amendment 12739 to House Bill 0916, please say aye. Opposed? The amendment goes on the bill. Now you can kindly explain the amended bill.
Thank you, Mr. Chairman. This legislation is an effort to stand up for our patients, many who are battling cancer and others who are chronically ill, by addressing unfair payer practices known as white bagging. White bagging requires the purchases of these infusion drugs through insurance preferred specialty pharmacies. Often these pharmacies are owned and controlled by the insurer. These medications are often tailored to the patient's needs during each visit, and many times dosing or even medications need to be changed based on the results of imaging or their labs. The current process adds administrative burden on the providers by requiring that additional planning and coordination, which can delay treatment due to transport times and the unpredictability of dosing needed for patients at the point of administration. This legislation seeks to allow patients the flexibility to obtain medicines from pharmacies of their choice. It ensures patients more timely and safer access to these life-saving medications. It allows providers to spend time caring for their patients, and it protects patients by requiring coverage of their medication at the same level, regardless of where the medication is sourced. In summary, I believe this legislation is about allowing patients the right to medication, the right medication, the right dosage, and at the right time. And with that, Mr. Chairman, I stand ready for questions.
Well, thank you for the explanation. Members, we do have testimony, but I think we can go ahead and take on questions that you have for the presenter. But keep in mind, we will have testimony from the Tennessee Hospital Association as well as America's Health Insurance Plans. Do you have questions? Okay. Representative Freeman, you're recognized.
Thank you, Chairman. And I guess I just want some clarity on what you're addressing here. I've been through within my family chemo treatments, and we've done both hospital administered. There was to your point, every time we went in, there was blood work drawn, and the mix was a little different. And then we did white bag as well after the fact, and both worked properly. And I guess I'm not sure. Are you saying that doesn't happen today, or it's not allowed to take place today?
No.
Chairman Rudder.
Sometimes it happens where that a patient's labs or, their blood work, something's off, and they do have to have their infusion drugs reformulated. And the way white bagging works is that if the hospital or the provider would not be paid for administering or mixing those drugs in their pharmacies, and sometimes that patient may have to go home and come back with the white bagging situation, because the insurance companies are controlling those medications through their specialty pharmacies and not allowing the hospital's pharmacies to mix the medications in some instances.
You're recognized.
So the problem that you're trying to solve is what? Allowing choice of patients to pick where they want to get their medication, or allowing a pharmacy to mix a white bag, or?
Well, what
Representative.
this legislation actually would eliminate white bagging, and it would move it back into the hospitals and the infusion centers to have control of formulating the drugs at their pharmacies.
Representative Freeman.
Would it extend to what's also called brown bagging as well?
This is only about white bagging.
Just white bagging. Yeah, I mean, I can't wait to hear testimony, but you know, there are a continuum of care, and you're using the example of the most specialized, the most difficult to mix, and I appreciate that. But there are instances where white bagging, I would assume, can save money and allow patients to have equal access to care. And you know, I have spent more time in the hospital over the last 2 years than I would ever care to again in my life, and regularly look at the bills, and I see, you know, a Tylenol sold for $20, or and allowing a hospital to control what is already an extremely you know, difficult financial situation, and not allowing others an opportunity to do it. You know, when I was sitting out in the infusion room waiting for my wife to come back, the financial assistance room was right around the corner, and I would tear up watching these people go in, you know, hands down, heads down, tears in their eyes, going through what is already an extremely difficult situation, but then not having the money to pay for it. And I guess I need to better believe that this is actually going to save money and be a more cost-effective manner, because my experience is that's not how it's operated. So.
Chair Ledorder.
I'm thankful that you had a positive experience with the infusion centers. There are people that don't, and I just want to say this is about patience. To me, it's not about how much money. And I do understand that the insurance companies want to make money and save money so that they don't have to pay huge premiums and protect consumers. But I also understand that hospitals want to be in that arena too. And sometimes when patients are at those hospitals and they cannot get the drugs that they need on that particular day, then that patient is inconvenienced when they're fighting for their life. That is where I'm coming from on this piece of legislation. And maybe if we were to go out of session and you were to speak to the people that are here to testify, they can better explain that to all of you.
We will do that. Just to summarize the matter, the situation is usually an oncology patient, but others also need an IV infusion. These drugs being so expensive, the insurance company has a contracted provider for those things, and those bags of medications to be infused are sent to the hospital. So bags are there waiting for the patient. Patient arrives for their medication. Their testing reveals that their needs are different. So you cannot use the medication that's already there. What is wrong is to send the patient home, delay their treatment until the insurance company can come up and once again, through their contracted pharmacy or well, let's say pharmacy, delivers the medications to the hospital. That is traumatic because sometimes patients have come from far away, as well as delay in their treatment. The other option is that the hospital goes ahead and provides the medication and infusion that the patient needs, and the insurers pay them. Insurers are trying to save money by having contract people mix those medications. On the other hand, the hospital costs are usually higher. And that is what I think briefly, is that fair to say that's really the situation? I think we need to keep the purpose for insurers and hospitals And our duty is to our citizens and the patients. And the purpose is to keep it in mind what is best for them. And can there be a reasonable compromise about the cost? Representative Mitchell, you recognize, sir.
Yeah, thank you, Mr. Chairman. So I agree with what you're trying to do, but I'm just trying to figure out, are we getting there? Will this cover TennCare?
TennCare, that was part of the amendment. They are carved out.
So will this cover ERISA plans?
You recognized.
Sorry.
I know TennCare and I will tell you the carve out. Cover kids. TennCare and Cover Kids are exempt from this legislation.
Representative Mitchell.
I think ERISA plans are too, and that's the majority of plans. How about Blue Cross?
Blue Cross Blue Shield is okay with this bill.
They're okay.
Mhm.
So it will affect them.
I just know that they've signed off on this legislation.
Okay. But my question is, I just don't want to do something, like my colleague at the end, talking about the people walking down the hall, wringing their hands because they know they can't afford the drugs. I'm scared that we're passing something that the people who probably need the assistance the most, we're not going to help. We're not going to, ERISA plans cover the most employees. Anyway, most of the large employers are ERISA plan. I'm just who are we helping? Just what percentage of the population? And I'm thinking, unfortunately, even with your best efforts, it's a minute population we're even going to be able to help. But I appreciate your work. Thanks.
Chair Lady Rudder.
Thank you for your remarks.
Chairman Terry, you recognize. Okay. Okay, you'll wait till. We do have testimony, so we will go out of session. And the testifiers, Mr. Wright, no, okay, Mr. Adams and Mr. Blair from the Tennessee Hospital Association. Thank you. You know the parade. Kindly make sure your mic is on and identify yourself.
Thank you, Mr. Chairman. Zach Blair with Tennessee Hospital Association. I appreciate the questions that we've received, and I'll be very brief because I want to turn it over to someone who's a lot smarter than me as it relates to this subject. Chair Lady Rudder, her explanation and what we are aiming to do is to simply get patients out of the middle in these circumstances. I'll let Rodney address some of the questions regarding coverage from Representative Mitchell and Representative Freeman. I think he can give some more information that would be very helpful. But Rodney Adams is our Vice President of Research and Reimbursement and has spent a long time working on this issue. And I think it would be beneficial for the committee to hear from him, Mr. Chairman.
Sure. Mr. Adams, I forgot to mention you have 3 minutes.
Thank you, Chairman Kumar. And thank you, committee. I appreciate the opportunity to be here. Chair Lady Rudder did provide a good summary, and the questions have been very good. And we are certainly sympathetic with Representative Freeman's comments around the patients who are struggling. I worked in hospitals for 17 years, and some of those patients sat in my office with tears in their eyes. And so I'm very familiar with the situation that these families are facing. What I would say to that is the cost from a patient's perspective many times is more inexpensive because they do meet a maximum out of pocket. And there's charitable care that's available at the hospitals and many of those outpatient infusion clinics. The specialty pharmacies typically do not offer charitable care. And so although those rates that the insurer are paying may be slightly cheaper, the patient is left in the middle of that without the ability to receive the charity care that they were going in that financial aid office and receiving at that provider likely that you were at. We do agree that patients need to be out of the middle of this. Patients come in, they've been given a stressful diagnosis. Many times it's a life-changing and life-altering diagnosis. And the physician orders medicine, schedules them for their infusion, and you would think that that should be the end of the story, that they should get the medicine that they need. But that many times is not the case. It's fortunate that you've had good experiences on both sides, and that's not always the case. We have patients who come into outpatient infusion centers and hospitals to receive that medication, only to find out that the medication has not arrived. So they must be sent away to wait, and their disease continues to progress while they wait on the medication. There are 5 rights for patient medication administration. You must verify it's the right patient, the right medication, the right dose, at the right time, given in the right route. And white bagging flies in the face of 3 of those rights. You cannot always confirm that it's the right medication because that medication may need to change based on the results of their labs or imaging. You cannot always verify it's going to be the right dose because that dose needs to change based on the results of those labs and imaging. And you can't always verify that it's going to be at the right time because of the delays that are associated with this process that has been inserted by the payers. And so we appreciate your support. To Representative Mitchell's question around the percentage of the population that is impacted, we understand it may be 2 out of 10 patients or 3 out of 10 patients that we can help through this legislation. I do not feel that that should be a deterrent in moving forward. If we have the opportunity to help 3 out of 10 Tennesseans, I think we should seize the opportunity to do that and continue to fight for more as the opportunities present itself. There was also a question raised about patients having the option. There's nothing in this bill that eliminates white bagging from being an option if the patient and provider decide that that is the best opportunity for the best avenue for the patient. But that should be a decision that can be made between the patient and the provider and not solely made by their payer.
Thank you. Members, do we have questions? Jim and Terry?
Thank you. And that was actually the question I was going to ask was, does this actually prohibit a patient from white bagging? So my follow-up question to that would be, say they've worked it out and the patient does white bag with this specialty pharmacy and brings the drug there. And you talk about your 5 rights, and once it gets there and you don't have the right dose, or maybe it's not the right time, or something has changed, is there a penalty towards the patient in this legislation?
Mr. Adams?
Thank you, Chairman Kumar. Chairman Terry, no, there is no penalty to the patient. The patient would, in the way this legislation is drafted, pay the same out of pocket, whether according to the contracted rates. And so if they get there and that drug is not mixed appropriately, is not the right dose, or is no longer the right medication that the patient needs, the provider would have the opportunity to administer that medication and be reimbursed at the rate for which they're contracted. So there is no penalty for the patient. They're not going to pay for the drug twice.
Jim and Terry?
All right, and thank you. And so would the insurance company pay for the drug twice? Because now there's been an agreement at a specialty pharmacy, they've gotten it, they brought it there, and then you've determined that it doesn't meet the 5 rights, and now you have your own pharmacy at the hospital that's going to mix the drug. Now all of a sudden there's one drug that you have to waste. What happens in that situation?
Mr. Adams?
Thank you, Chairman Kumar. That would be based on the contract between the payer and the specialty pharmacy. So as the provider, there would only be one claim that goes in on that. And claims can only be administered from a provider standpoint when a medication is given to a patient. The contract between the payer and their specialty pharmacy would determine how they handle waste. Is that waste that comes out of the specialty pharmacy's proceeds, or do they require the payer to pay that? So that's not a contract that I'm privy to.
Jim and Terry?
Thank you. So in current situation, if you white bag and you go to the specialty pharmacy and you come in, it would basically, what's currently happening is it'd be wasted, and whatever's currently occurring now would still occur. Is that your agreement?
Mr. Adams?
Yes, that is correct.
All right, thank you.
Representative Hemmer, you recognize.
Thank you, Mr. Chairman. Thank you, Mr. Adams, for your testimony. Just curious, is there any patients that are getting these drugs today, white bagging, et cetera, that under this legislation, that are not getting these drugs today, or these, under this legislation, is there any going to be any more access to these drugs?
Mr. Adams?
Thank you, Representative Hemmer. I don't think that there's going to change in the number of patients who are receiving these drugs. It is really more about the timeliness of the medications that are administered. We have seen cases where patients are waiting 1 week up to 5 or 6 weeks for the medication that's been ordered. And this is seeking to eliminate that. There's normally follow-up by the provider, the physician who orders this drug, to ensure that his or her patients receive what they need.
Representative Hemmer?
Thank you. And since this will likely increase the total cost in the healthcare system for these drugs and this patient population that isn't carved out, will this likely increase premiums for those groups?
Mr. Adams?
Thank you. The premiums are set by the insurance companies. I would say that premiums have not gone down as a result of the white bagging processes that have been implemented. And so it would be my stance that those have only sought to generate excess profits.
Okay. Just curious, how prevalent is the situation out of 100 patients that arrive for treatment? How often does it happen that one of the 3 rights are not met?
Thank you, Chairman Kumar. That is a difficult question to answer. There are thousands of patients who are receiving these medications across the state. And so what we do know is that 92% of practices have reported an issue with the white bagging process. Now, that does not mean that it happens on 92% of cases who come in, but that does mean that 92 out of 100 clinics have reported issues associated with one of those 3 rights.
I'm surprised that we don't know the prevalence of the situation. Representative Mitchell?
Yeah, thank you, Mr. Chair. So I'm just trying to figure out, who this is going to cover. So I'm just scared someone's going to see a news story about this passing and they're going to get excited and think it affects them because, if someone, let's say they work for the state, employee, well, it's not going to cover them because they're in a ERISA plan. They work for one of the largest employer, the top 50 largest employers in this state. It's not going to cover any of those people because they're all ERISA plans. Someone with a Blue Cross Blue Shield card in their wallet, it's not going to cover those folks. Someone on TennCare, Medicaid, Medicare, it's not going to cover those folks. I'm just trying to figure out who it is going to cover. So when someone reads a story of this and gets excited that, their problem may be solved, who are those people? And I think it's going to be such a narrow scope. It's going to be 10 to 12% of the market that I am concerned about premiums going up.
Mr. Adams?
Sure. And I appreciate your concern on that. I think that Medicare is not impacted. Medicare does not have contracts that require white bagging. And so they are currently excluded. ERISA plans are based on federal law, and it will be up to how the rules are promulgated and interpreted by the state as a result of the legislation, should it pass, to determine if those plans are subject or if they believe it could be included. That issue exists on any state legislation that's passed around payers today, as far as ERISA plans go. From a Medicaid standpoint, many of those patients are already being treated in the hospitals, and I don't know how white bagging is not nearly as prevalent in the Medicaid population.
The thought comes to mind that if, as you're saying, only a small number of people will be affected, that means only small amount of costs will be generated. You recognize?
Yes, Mr. Chair. No, what we're talking about is the costless drugs. I can tell you on an ERISA plan, for example, if this goes into a ERISA plan and they have 100 employees and all of a sudden there's a 6-figure drug in that ERISA plan, no, I can guarantee you it affects that plan greatly. But again, my question is for the people who think this is going to help them, I want to know who this is, who this is going to affect, what type of insurance coverage or what carrier do they have to have this is going to be applied to.
Mr. Adams?
Thank you, Chairman Kumar. It would apply to all fully insured business in the state of Tennessee. You said it does not apply to Blue Cross. Blue Cross's plan does not the same as the other payers plan in that they allow buy and bill. They allow providers to join the network, buy the drug and bill the drug and prepare it there and do not require it to be obtained from their specialty pharmacy. They do have that as an option, but it is not a requirement.
This question may also be answered by the insurance plans for you. Any other questions? Representative Davis?
Thank you, Mr. Chairman. So do the hospitals have the ability to negotiate any of those pharmaceutical prices? I know that, that's kind of one of the things that a lot of the insurance companies do have that ability to do so because you don't want that cost to be, especially when a lot of these are specialty type drugs. And, we want to make sure that we are helping out the payer.
Mr. Adams?
Thank you, Chairman Kumar. Representative Davis, that's absolutely correct. Contracts are renegotiated on average every 2 to 3 years between the health plans and the health systems or any provider. This is not a bill that's only covering hospitals. This covers outpatient infusion centers and others as well. And so this is not just a hospital bill, but they do have the opportunity, and those rates are outlined and were already negotiated before the payers implemented white bagging processes. And so those rates are defined in their contracts, and should the payer seek to lower those, they have that opportunity every 2 to 3 years in the open negotiation process where they renegotiate.
Representative Davis?
Thank you. The other question I have has to do with if there is that situation that an individual comes in and based upon their blood work or any sort of testing that they need to have that medication altered or adjusted, do they not have the ability to the doctor's office or the infusion center to reach out to that insurance company and get some sort of override to have that medication compounded there on site?
Mr. Adams?
Thank you. There's always an option to reach out. The majority of those approvals take many days, and many times the payers say, no, we'll send it from our specialty pharmacy if it needs to be changed. And so they do not allow that patient to necessarily receive the treatment while they're there. While there are override processes, they are difficult and arduous to go through and are not patient-centered at all.
Representative Davis? Chairman Sparks, you're recognized.
Yes, sir. Chairman, I heard Representative Freeman's testimony. I just had a sister go through breast cancer surgery just a few days ago. So it's been on my mind, with what she's having to deal with. I just text her asking about her medicine costs, that sort of thing. But are we shifting costs? Will this just shift cost and increase out-of-pocket expenses for the patients?
Mr. Adams?
Thank you. Representative Sparks, no, this would not increase out-of-pocket expenses for patients. Patients are protected in that they have a maximum out-of-pocket on any services that they receive. And once they reach that maximum out-of-pocket, they're no longer exposed at all. And as I talked with or spoke to Mr. Representative Freeman's question, many of the providers that provide infusion services do offer charitable care for patients who are out of work or unable to work while they're going through their treatments.
Bottom line is you're assuring us this is going to benefit the patient.
Yes, sir.
Okay,
I'm
thanks,
sorry.
sir.
All right. Chairman Sparks? Okay. Chairman Terry?
Thank you, and appreciate you coming back with me. So for patient convenience and for treating them on that day, this does, in your opinion, would improve their outcomes?
Mr. Adams?
Yes, this is solely designed to improve patient access to the clinician administered drugs.
And then,
Jim and Tara?
thank you. So so for the patients, this is good. For the cost, the question that I have, and it may be for Mr. Blair, may be able to answer this. So dealing with manufacturing, I know there's like conversion factors in hospitals, and these facilities can charge for supplies and manufacturing of this. What percentage compared to a specialty pharmacy is there an upcharge for these drugs if they were manufactured at the facility versus at a specialty pharmacy?
Mr. Adams or Mr. Blair?
Yeah, the range is very different depending on the contract that the payer has with the provider. And so there could be drugs that are virtually the same. There could be drugs that are some multiplier larger in reimbursement than what the specialty pharmacy contract with the payer is. And so that is going to be dependent on the contracts that Representative Davis spoke to as that are negotiated with each provider.
Jim and Tara?
So is there anything in this that would match that rate so that we're not, so that our premiums can stay lower? Or is there anything in there in this bill that would allow us to match those rates?
Mr. Adams?
No, there is not. And if I might, I would liken this to the cost of hotel rooms. The cost of hotel rooms are different depending on where you go. The cost of a hotel room in Nashville is very different than the cost of a hotel room in Winchester. And so those are negotiated, and what is determined to be fair is between the payer and the provider as a part of the open negotiation process that they go through. I don't think that setting a rate is what the market would bear. And I think that's what this is really about. There are rates that are negotiated between payers and providers, and those should be honored for the life of a contract.
Jim and Tara?
Yeah, just one more comment, and obviously saving the patients the inconvenience and the cost associated with the drug being there to meet those 5 rights may ultimately offset the waste that you might have from white bagging. I just don't know those costs, and that's what I'm trying to think about. What's up in the air? I do think that for patients, it does improve our outcomes. But thank you for your testimony.
Any other questions? Representative Freeman, you're recognized.
Thank you very much. So I've got a couple of questions. One, I guess I want to clarify the hotel room comment, because the price of a hotel room is based on location and availability, and we're talking about a drug that should be able to be shipped nationwide. And to me, I want you to explain that a little bit more, because I don't think that rings true. If I'm, regardless of where I receive my medication, that should not increase or decrease the cost of the medication, right?
Mr. Adams, you want to pick a better angle?
No, I'm good with that angle, because the cost associated is different. The cost to operate a hotel in one location may be different than the cost to operate a hotel in another location. And so the cost at a specialty pharmacy may be different, because that is the only service that they provide. And shipping that medication is a different cost than what the providers incur. And they also don't offer the charitable care and the other components that are at cost as well for the providers in these infusion clinics and hospitals.
Thank you for
Representative Freeman?
Thank you for that comment. Yeah, that was much clearer. We're talking a lot about chemo medication. What other drugs are mixed or formulated, or whatever, in these specialty
Mr. Adams?
clinics?
Sure. Thank you. And thank you for the opportunity to clarify what I meant by the previous, based on your previous question. There are drugs considered for other chronic conditions. So there are kidney conditions. Wagner's disease is a common an uncommon disease that commonly requires infusion therapy. There are drugs that are associated with neurological disorders such as IVIG that are also a part of this. So it is not simply a chemotherapy. There are many drugs that are associated with clinician administered.
And what percent of those other drugs outside of chemo would make up this business?
Mr. Adams?
Thank you. I don't know that there's, I don't have a percentage per se. Chemo is the majority of the drugs that are clinician administered. But at the infusion clinic where I worked previously when I was on the provider side, about 15% of the drugs were not associated with cancer therapy.
Last question. And then I just want to clarify another statement you made about increasing patient access to drugs or patient care. I heard you say that the decision to use on-site facility versus white bag will be made by provider. Talk through that again. How's that decision made?
Mr. Adams?
Thank you. That decision should be made between the provider, the ordering physician, and the patient as to what is best for the patient and what best meets their needs from a clinical standpoint.
Got it. Okay. Thank
Dr.
you.
Freeman?
I'm good. Thanks.
To keep it in perspective, once again, patients are protected against financial costs because they are caps on their out-of-pocket expenses. But as far as the timing of treatment and delay, they are still at risk for that. Yeah. Any other questions? Otherwise, we do have Rep. Davis. Did you have a question? Okay. So I think it's time to move on to Chairman Terry.
Thank you. I apologize for all the questions, but things keep popping in my head. Would this cover things like Crohn's disease or inflammatory bowel disease, things like that? So it could very well be that it may be necessary to get somebody on a dose to begin with, and you figure out where the balance is, and then move away from it being at the facility to where they're on a standard dose, and then they can white bag at a cheaper cost at a standard dose. Is that correct?
Mr. Adams?
Chairman Terry, yes, the scenarios are endless as to the medications as well as what is best for the patient. We are advocating strongly that decision should be made between the provider and the patient based on what is best for them and their disease state at the time, and not mandated by a third party that has never seen the patient.
Thank you.
Representative Davis, you're recognized.
I apologize, but something you said sparked that. Thank you so much, Mr. Chairman. So my question then is if the patient and the provider then determine that white bagging is the best solution for them, what's the difference? What's the reasoning or the rationale if the white bagging is actually benefits them cost-wise? Why? And then you've also said that those costs are capped at out-of-pocket. I guess I'm confused as to where's the savings if there's already a cap. I'm not clear as to how y'all.
Okay. Mr. Blair?
Representative Davis, thank you for that question. I think you bring up a good point because this bill does not prohibit the ability to obtain medications in this way. It allows buy and bill, but it doesn't prohibit anyone from going and obtaining the drugs through the white bagging process. So what we are simply asking for as part of this bill is that if there are circumstances where buy and bill is the most appropriate to obtain and administer that medication on site, that we have that option to do that we do not have now.
Representative Davis? Yeah. Chairman Sparks?
I don't want to muddy the waters anymore. It's already muddy, but let me ask you, PBMs, how do PBMs factor into this?
You are certainly muddying the waters.
I'm sorry. Just gotta ask.
Mr. Adams, can you clarify?
Sure. So PBMs, there was a reform bill that was passed in 2021 that prohibits this action on PBMs. The benefit was then moved by many payers to a medical benefit as opposed to under the pharmacy benefit. So the white bagging process continued. This seeks to close that loophole that was generated from the legislation from 2021.
Well, I just want to say, for the record, you're seeing people struggle, like Bob's wife, my sister. Drug costs have escalated outpacing inflation. It's a serious issue, and I really wish every member up here should chime in on this because it's something this committee really we should challenge. You look at what Mark Cuban's doing; he's shaking up the market. That's why I really like this guy with Mark Cuban. What's it? Drug Cost Plus, I believe it is. He's just shaking it up. He's bringing out transparency. He's challenging the conventional wisdom, the status quo, and he's making an impact, and it's helping the consumer. And that's the great thing about the free market. And I think everybody up here likes the free market. Y'all nod your head if you do. Maybe there's a few up here that don't like the free market. But anyways, I'm going to support legislation. It's a confusing topic. I know the sponsor. I know her heart's in the right place, and I hope I didn't muddy the waters for y'all. Thank you.
Thank you for your perspective. Gentlemen, thank you very much for your time.
Chairman, thank
and
you. Thank you for the opportunity.
Thank you. Members, we do have a representative from the insurance industry to explain their perspective on the matter. Mr. Trey Moore, kindly make sure your mic is on and identify yourself.
Good morning, Trey Moore on behalf of America's Health Insurance Plans. Thank you, Mr. Chairman, for the opportunity to speak. First and foremost, I agree with Representative Sparks that the sponsor's heart is in the right place. I think that's where she's coming from. I think, unfortunately, we just have a disagreement on whether this causes more harm than good. I think two things that we can all agree on, hopefully, is that prices for cancer drugs are too high. They are by far most expensive in hospital settings through a buy and bill method that the advocates are promoting here today. And not marginally more expensive, multiples more expensive. Let's see, in the past 5 years, and these are markups on drugs that are extremely expensive to begin with, but in the past 5 years, almost half of new cancer drugs launch prices have exceeded $200,000. 200. We agree that cancer diagnosis is a burden on patients. We also agree that that burden doesn't stop with treatment. The financial burden is significant. If I've already lost you here and you're bored, I would encourage you on your laptop or your tablet just to Google hospital markups, cancer drugs, and look at some of the top results you're going to get. Hospitals, massive cancer drug markups. Hospitals significantly marking up cost of cancer treatment. Hospitals mark up discounted cancer drugs as much as 11 times. Hospitals mark up cancer drugs by 10 times their value. It was, I guess, the analogy was to hotel rates made by the advocate earlier. And I think Representative Freeman had a good follow-up question there. It's, of course, different hotels have different rates. I guess our question today, since more than half of the hospitals in Tennessee have nonprofit status, is if a nonprofit hotel should charge the same as Four Seasons downtown on the river, especially when they are subsidized by taxpayers already. And in many cases are buying these drugs at considerable discounts through the 340B program, which we think was designed to lessen the burden on cancer patients to begin with. What the data shows in these studies underlying the headlines I just read were that they charge even when they use the 340B pricing to get better discounts on the drugs, they still charge commercial rates to these patients.
Mr. Moore, I forgot to remind you that it's 3 minutes, so kindly take another minute.
Thank you, sir.
Thank you.
The average markup on a hospital treatment, this is per treatment in a commercial setting, over a specialty pharmacy rate, which the bill would seek to prohibit, granted for 20% or 10% of the market. The average markup in a hospital setting is $8,200 more than the patient would be charged for the same drug in the same setting. It's significant. Now, patients, let's not forget, there's a lot of talk about insurance companies and hospitals, but at the top of the bill that the hospital submits is the patient's name. It's not the insurance company's name. So if there's a discrepancy over this pricing, over who owes what, that burden gets hung around the neck of the cancer patient and their family, not the insurance company. So I think as far as the carve-outs, we think it create the numerous carve-outs. TennCare is carved out. State employees are carved out. If it's a patient safety issue, I would think you would want your staff to benefit from it. As mentioned, the largest commercial health insurer in the state is also carved out. We think, regardless of a fairness argument, that's going to create a huge administrative burden on hospitals, patients, insurance companies, their health plans, or their employers. Who's going to know who's covered by this bill or not? And the last thing we want to do is create more confusion at the site of care for a patient seeking cancer treatment. And I'll stop there and answer any questions.
Well, thank you. Members, do we have questions for Mr. Moore? Representative Freeman, you're recognized.
Thank you, Chairman. Mr. Moore, thank you for being here. And I just want to share another story with the committee. When my wife was diagnosed, and not to share too much personal information, I don't think she'd really care, but she had a BRCA gene of undetermined significance. And there was a drug that was available that treated BRCA recipients that our oncologist thought she would benefit from. When it was quoted from the hospital, she said, but I have to really fight to get it covered through insurance if it comes through the hospital because of the markup. And those that know you being a big shot, I said, well, what's it cost? I mean, let's just pay out of pocket. It's $215,000. And to be put on a decision as to whether or not to save your wife's life over money was a difficult play, is a difficult reality to sit in. Thank goodness our oncologist fought to get it through insurance and get it approved, and so we didn't have to buy it through the hospital. But these are real decisions that patients in Tennessee are making every day, and the benefit that I have of being in Nashville and having access to great health care shouldn't dictate my having better service. So I really encourage everybody to really dig in on this, because this could really shift the cost of healthcare to a point that it's not going to be affordable and it will raise premiums. So thank you.
Mr. Moore?
If I may, just for reference, Medicare reimburses hospitals for these drugs at their average sales price plus 6%. And that just gives you sort of a reference or scale. What we're talking about is average sales price plus, or wholesale acquisition costs plus 500%. It's egregious. And white bagging only exists, in our opinion, because of the egregious pricing that hospitals promoted with these drugs. And it was, to Representative Sparks' point, a free market solution. Now, is it perfect? No. Could it be improved? Probably. As far as taking care of the patient first and foremost, most plans have exceptions policies or override provisions so that the patient doesn't have to be sent home. We'd be open to a conversation about codifying that in some way to make sure every plan has to do that to take care of the patient. But that doesn't add any extra cost to the patient who's going through these treatments. Secondly, it was mentioned by the Hospital Association that Blue Cross was carved out because they let anybody in their network. I would remind the committee that what we're talking about here is a specialty pharmacy within a hospital setting. So it is a hospital-owned specialty pharmacy. We've had on the books since the 90s provision. It's 56.7.2359. It's called the Any Willing Pharmacy provision. And I'll just read it for you. No health insurance issuer and no managed health insurance issuer may deny any licensed pharmacy or licensed pharmacist the right to participate as a participating provider in any policy, contract, or plan on the same terms and conditions that are offered to any other provider of pharmacy services under the policy. So the solution is there. They can just take their specialty pharmacy that's on site at the hospital, join the plan's various specialty pharmacy networks, and dispense it themselves. The question then is, well, why don't they do that? And the answer is, in our estimation, because when they bill it through the hospital instead of their specialty pharmacy network, they're going to bill it at 5 to 10 times as much for the same drug in the same setting. We see it just as a pure financial play.
Well, thank you. Chairman Terry?
Thank you. Appreciate your testimony. Talking about costs and losses for this, and we're talking about markup. What, in the number of cases that you might see in this, waste from the specialty pharmacy from white bagging versus the markup cost, where does that lie in this?
I
Ms.
haven't,
Moore?
thank you, Mr. Chairman, sorry. I haven't seen any data, but I guess common sense says if the white bagging program is an effort to save money for the insurer, if they were losing more money on that than paying the hospital for buy and bill, they probably wouldn't impose a white bagging program. I think all of us or all of you on the committee know that insurance companies watch the profit and loss fairly closely. They're actually required to by law. But if they were upside down through waste, then, but I don't have any hard data on that.
Chairman Terry?
I was talking about waste to you. So if you're paying, or the insurers are paying a specialty pharmacy because the drug has been white bagged and they've wasted it, now you have to pay for a new drug and the white bag. What's the cost of that versus the markup? Do you have any of those
Well, I
numbers?
mean, I guess the average markup, as I said, and I think maybe some of you have in your inbox, is $8,200 per treatment. So I think it would take a lot of waste to capture, to outweigh the cost differential there, right? I mean, if you're thinking, if the specialty pharmacy charge is $10, then the hospital charge is going to be $8,210 on average, right? So you would need a lot of wasted drugs in order to put that, I guess, program, make it financially unviable. But just because the margins are so much higher on the hospital side that even with waste, it's still a much better option financially for the
Chairman
patient and the
Terry?
plan.
All right, thank you. And during these discussions, and I wasn't privy to any of those meetings or discussions, a few years ago, there was a bill dealing with proton therapy, and there was a clause within it that put it on parity with radiation therapy. Were there any
IMRT.
Was there any discussion, or you said there's this significant markup, but having the on-site be with at least within a maybe 5-10% range as opposed to this huge markup? Was there any discussion about that?
We would,
Mr. Moore?
I don't want to get ahead of my skis, but I suspect we would support any language that set some sort of reasonable cap on the markup.
Okay.
Chairman Terry?
I'm good, thank you.
Representative Hemmer, you're recognized.
Thank you, Mr. Chairman. Thank you, Mr. Moore. Is your group concerned with having different rules for different insurance companies in your membership?
I think generally we are concerned that everybody's not in a consistent or on a consistent playing field. I think, and not necessarily from, and I guess there's a fairness argument there too, but I think most importantly from our standpoint, confusion at the site of care when you're talking about treatments like this is a huge problem. I think this bill ostensibly seeks to address that, right? I mean, the whole point, as I understand it, is to avoid some confusion. We just think this actually creates more confusion because hospitals are generally not going to know if they're covered by it or not, or if the patient is covered by it or not. Because, for instance, I could show up with a Cigna card, right? And as a state employee plan, I'm not covered. But as a otherwise commercially insured plan, if it's fully insured, I am covered. But if it's an ERISA plan, I'm not covered, right? So you could see if we play that out and the hospital assumes that they are covered and dispenses it themselves, charges the patient, let's say tens of thousands of dollars. In that scenario, the payer might not be covered, right? Because that payer has a white bagging program. It should have been dispensed from the specialty pharmacy.
Representative Hammer.
Would the insurer contract with and pay for these services at the hospital if they were cheaper?
I think so. And as I said, hospitals could ensure that happens simply by exercising their right under state law currently and joining the specialty pharmacy network. There's not a single insurer under state law that could deny them their ability to do that.
Members, in interest of time, we need to move on, but we do have Representative Davis on the list.
I'll be quick. I just wanted to, you answered, thank you, Mr. Chairman. You answered that with regard to the specialty pharmacy plan network, that hospitals could join that and be considered in that. What was that TCA again?
56-7-2359. I think it was passed in 1998.
Okay, so that's the any willing pharmacy,
Correct.
right?
Yeah.
Kind of that.
And all of these hospitals that are dispensing these drugs have a specialty pharmacy. I mean, manufacturers are not going to send or ship these light sensitive, temp sensitive, expensive drugs to a pharmacy that doesn't have the capability to store them properly.
Okay. And so how many hospitals have joined into the specialty pharmacy plan?
I have no idea, but they're all entitled to.
Okay.
Well, thank you. Thank you, Representative Ritchie, for giving us a little more time. Mr. Moore, thank you for explaining and enlightening us. Thank you. Members, we'll go back into the session. Do we have any questions for Chair Lady Rudder? Seeing none and questions been called, we are voting on House Bill 0916. All those in favor, please say aye.
Aye.
Opposed?
No.
We don't have a way to measure decibels. Madam Clerk, please call the roll.
Representative Sapicki? Sapicki votes aye. Representative Davis? No. Davis votes no. Representative Freeman?
No.
Freeman votes no. Representative Helton Haynes?
Aye.
Helton Haynes votes aye. Representative Hemmer?
No.
Hemmer votes no. Representative Hicks of Hawkins?
Aye.
Hicks votes aye. Representative Hill? Hill votes aye. Representative Johnson of Montgomery?
Aye.
Johnson votes aye. Representative Johnson of Knox? No. Johnson votes no. Representative Lafferty? Lafferty votes aye. Representative Mitchell?
No.
Mitchell votes no. Representative Ritchie?
Aye.
Ritchie votes aye. Representative Rudd?
Aye.
Rudd votes aye. Representative Rudder? Representative Sparks? Rudder votes aye. Representative Sparks? Sparks votes no. Representative Terry?
Aye.
Terry votes aye. Representative Thompson?
No.
Thompson votes no. Vice Chairman Martin of Carroll? Martin votes aye. Chairman Kumar,
Aye.
Mr. Chairman, you have 12 ayes, 7 nays, 0 present not voting.
I should have been able to tell. The bill passes and goes on to calendar and rules. Thank
Thank you, Mr. Chairman and committee.
Members, we do have two presentations. We'll try to accommodate them and finish up on the work. Hopefully we can. Department of Commerce and Insurance. They are going to talk to us for a few minutes about rate setting. Gentlemen, you know the routine. And Mr. Huddleston, is that your presentations about rate setting?
Thank you, Chairman. We're going to touch on rates, but this is more of a general presentation over insurance regulation. We do have a little bit in here about rate increases, but it's more of a overview of what several of our sections do to regulate insurance.
Okay. Well, hopefully you can finish it in 10 minutes.
We'll do our best. Thank you, Chairman.
Thank you.
So first of all, Chairman, Vice Chair, Committee, thank you for the invitation to come and present today. We will be brief, and we're going to talk, as I've said before, a large part of insurance is regulated at the state level. And our big job is to monitor for solvency and market conduct. So in other words, we want to make sure that insurance companies have money to pay the promises they make and that they pay those claims when they are supposed to. There's a variety of procedures that we use to meet this goal. And I have some of my directors here with me today to help explain what they do in that regulatory process. Trey Hancock is our Director of Financial Affairs. And then I have Stephanie Cope, Director of Policy and Rate Review, and Scott McNally, Director for Insurance. So they do a great job, and I can't brag enough about them. We have I think the best insurance department in the country, and also by several metrics, the most efficient, and glad to share those. If you want, I'll send those. But one thing that's a crucial consumer protection is that we have a robust and sustainable market with plenty of products for Tennesseans to choose from. We want consumers to be able to shop for what is right for them in a competitive market. And to that end, we advocate for a stable and healthy insurance market. We want to support conditions for investment into Tennessee and have a steady regulatory environment. So as I bring up the subject of market, I'm going to hand this off to Trey for a couple of minutes to talk about solvency monitoring and the market.
Mr. Hancock, recognized.
Yes, thank you. So quickly, I'll talk about the financial affairs section of the insurance division and what we do here. So we have about 2,040 insurance companies that are licensed in Tennessee and doing business. Of those, 63 of those are domestic to Tennessee, where we are the primary regulator. Most of those are actually headquartered in Tennessee, whether it's here in Middle Tennessee or even in Chattanooga, some in West Tennessee. And we add about 70 new companies every year. So these are companies that could be coming to Tennessee, or they're in another state and they're wanting to write business in Tennessee. So it's a robust insurance market in Tennessee, which is ultimately good for the consumers as they have a lot of choice. Bill mentioned solvency. So company solvency, we want to make sure those insurance companies are solvent, that they're reserving appropriately, that they're investing in accordance with statute. So we do a risk-focused analysis on the insurance companies in Tennessee to ensure that they're able to pay the claims that they're obliged to pay. And then finally, I want to talk about premium taxes. So the companies that are in Tennessee are actually, paying premium taxes based on their premium volume, and that contributes annually. So last fiscal year, that contributed $1.3 billion to the state general fund. And as you can see there, there's that's on $51.5 billion of premium that is written within the state. And I'll pitch it back to you, Bill.
Thanks, Trey. Next slide. Real quickly, one of the resources we used to efficiently regulate the market is the a membership with the National Association of Insurance Commissioners. We have we have a leadership role on the Life and Annuities Committee there. We are also a member of the International Committee. We work with several working groups there, and Commissioner is the chairman of the Southeast Zone this year. I would also like to take this time to thank Chairman and Vice Chairman for their engagement at the last national meeting and attendance. It was really, we were glad to have you all there and would invite any kind of participation we can get. So I think the next slide is, I'm going to touch on the rate increases a little bit, and in just a few minutes, Stephanie is going to talk about it a little bit more in depth, but right now, it was on the national news this morning as I drove in and listened, rates are rising everywhere across several lines for everybody, and it's a national issue. I thought last week APCIA did a good job kind of laying out some of the factors that relate to those rate increases. Inflation's a big one. Cost of replacement is a big one. Frequency and severity of claims, and they talked about those, and the cost of reinsurance. So, at the department, we get a lot of constituents' phone calls asking questions about different issues in insurance. And believe it or not, we do get the rate increase question. But one of the, and those conversations usually go okay. They're not always happy, but usually understanding of kind of what's going on after we talk about it. But one of the examples that I often use around this rate piece is just that ties all of those factors together, has to do with just the price or the cost of the asset that's being insured, whatever it is the payer's paying for. And the cost of replacement, for instance, today for a used car, there was the proverbial $5,000 used car that you would buy for your teenager, right? They're non-existent now. If you go to the used car market, those cars are now $10,000 cars. So usually when you kind of talk about that, it kind of brings all of these factors together, because it costs more, it's going to cost more to replace now. But it also leads to some good possible solutions to help the consumer with lowering premium. So I'll kind of, I guess, I'm going to save the rest of the rates for Stephanie to talk about here in a few minutes. And I would quickly like to move through some of the issues about the competitive market that Trey was talking about. To have that here in Tennessee relative to other states, some other states are really struggling. And while it is frustrating to see rate increases, restrictions in coverage, and higher deductibles, we in Tennessee still have, it's accessible for the most part for us to purchase. Other states, I was at a commissioners conference last week for NAIC, and I talked with some regulators from other states and some of their challenges that they have. A couple of them that stood out to me were Florida and California. There's some cautionary tales there that I think we could point to and learn from. For instance, in Florida, the property casualty market has gotten into they've just been devastated over the past few years with catastrophic events, high litigation costs. And as I talked to my fellow regulators from Florida, they're doing some things to try and reform that. They had a special legislative session last year and tried to pass some legislation to help them be more friendly to bring capital into the state. And they're making headway. It's just a big hole they've gotten into. Also, I think last week, APCIA, when they presented, referred to kind of some of the efforts in states to suppress rates. I think California was one of the states that they used as an example. And in addition to the rate suppression, they, up until recently, would not allow catastrophe modeling for wildfire. They would not allow their companies to take expense for reinsurance. And, those are pretty substantial pieces for a company that are important for capital to be invested. So what's happened in California is that for year after year, we have these accumulated losses because of those policies, and now you have insurers leaving and not writing policies at all, just due to the decision that's as simple as, do we continue to lose money, or leave the market? And I point to those as a couple of examples we could probably use to learn from. At this point, I would like to hand over the mic to Stephanie Cope to talk about rate and policy review.
Hello and good morning, everyone. I'm Stephanie Cope, Director of Policy Analysis for the department. I oversee the team that does form, rate, and rule review for all lines of business. So those are your life accident health products, as well as your property and casualty products. My team has a unique posture in that my commissioner, all of you guys, everyone in the audience, and all 7 million Tennesseans are consumers of the products that we approve, and we do not take that responsibility lightly. And I know we often talk about rate filings and what that looks like. And so I wanted to show from a functional perspective what that looks like when they're submitted to the state. So I put on the screen here an example of a personal auto filing. That is a typical filing that we see. In this filing, you'll see there are 3 companies included on the bottom. And one term we often refer to is an indicated actuarial rate. So that is what the insurance company's actuary says that they can take because of their losses and their loss experience. On the screen, you'll see it says 16.8% for 3 companies. However, they are taking much less than the indicated rate. They are taking 4, 6, and 3% in each given company. So when we talk about the health of our market, specifically auto in this case, that's a reflection of the healthy competitive market that Tennessee boasts here. And if we go to the next slide, this is an example of a form filing. So this company submitted 20 forms to us. They have a policy jacket and they have a handful of endorsements. Form filings can have 1 endorsement. They can have 200. It's going to vary per filing. And if we go to the next slide, a lot of these insurance companies submit filings like this, where insurance companies used to submit filings once to twice a year. We're seeing a lot more. And so our team is being very proactive in reviewing these filings to ensure speed to market, so our Tennessee consumers can reap the benefits of these products. And I will now turn it over to my colleague, Scott.
Thank you.
All right. Good morning. Yep, just barely still morning. Chairman, I'm Scott McAnally, Director of Insurance at the department. And I'm going to start off talking about examinations. So I want to begin with letting you all know that our director of our examinations section and our chief examiner, Joy Little, was recently recognized by the NAIC for her outstanding work. So we are very proud of that. Examinations for solvency is actually the oldest form of state insurance regulation. And we undertake examinations of our 63 domestics that Trey mentioned earlier on a 5-year rotating schedule. We are entitled to access all of the company's books and records during their examination process, but to maintain efficiency, we and all other states engage in risk-focused examinations. So we will start off with a survey of a company and then drill down on anything that looks vulnerable, suspicious, like it needs extra attention. In 2024, we are currently examining 1 property and casualty insurance company, 5 life and health insurance companies, 4 county mutuals, a prepaid legal insurance company, and a guarantee fund. Bill, could you do the next slide, please? In addition to financial condition, we also examine for market conduct, which leads us to our mental health parity slide. So we publish an annual report on mental health parity compliance in Tennessee. Mental health parity is the concept that if an insurer provides both medical surgical benefits and mental health benefits, the mental health benefits must be at least as generous as their medical and surgical benefits. The regulatory framework for mental health parity goes back 15 years and is present in both federal and state statute and is constantly evolving. There mental health parity rules, I think, under evaluation right now from the federal departments. But key findings in our state report for 2024 are that consumer complaints are down from 5 to 4, and that objections to company filings, those can come from either Stephanie's section or CMS, went from 9 to 0. So we were pleased to see that. We make the mental health parity report available on our website, and our adopted examination reports for companies are also available on our website, and we'll have any findings for mental health parity. Bill, get the next slide. So my last is going to be on our NAIC accreditation. So just like our insurance companies, we too are examined on a 5-year schedule by the NAIC. We most recently were fully accredited in 2021. So the NAIC developed its nationwide accreditation program in the 1990s in response to congressional pressure from company insolvencies that culminated in the congressional report, Broken Promises. Accreditation review teams are able to examine all of our functions, but give closest scrutiny to our examinations in our financial analysis sections. Accreditation status ensures that other states can trust our analysis of our 63 domestics and that we can trust the analysis done on the 2,000 insurance companies that operate here and are domiciled elsewhere. Staying current on certain NAIC model laws and regulations is also key to maintaining our accreditation, so we are very thankful to you all for your assistance in helping us stay current on those. And I'll return it to Bill now for our consumer insurance services.
Thanks, Scott. Our Director of Consumer Insurance Services, Vicki Trice, was going to join us, and I wish she were here to talk about this. Did not make it due to illness, but one of the things that I'm most proud of at our department is the efforts from Consumer Insurance Services and what they do through their mediation efforts. Last year, we had for 2023, had a record-breaking year in terms of funds returned to consumers. Consumer Insurance Services returned almost $17.5 million to consumers or complainants who had issues with claims. And it's just, really great function that we have to be able to do that and help out consumers. So really proud of Vicki and her section. I would also say, and I'll end on this, that they often do outreach events. So I would say if any of the members have, if they would like for us to come out to your districts, and we would love to hear ways to engage with, or ideas about how to engage with your constituents. That's my last slide here. I think, again, thank you, and glad to answer any questions.
Thank you. We'll definitely have more time for you when you come to our districts. We thank you for coming. We invited you, and I'm sorry you had to do a hurried presentation, but we appreciate the content.
Thank you, Chairman. We appreciate it.
Yeah. Thank you again. I would also like to say, while we are out of session, the presentation by TennCare and Finance Ways and Means is postponed to next week. Hopefully they can still make it, and we'll go back into the session without objection. We will go on to adjourn. Thank you. All right.